I think according to the literature, it's close to 50%. But then again, you need to consider what kind of coronary artery disease are we talking about, and then if it's some kind of a stenosis that you will consider treating, then it will be probably around 10% of the patients with severe aortic stenosis. So before we did the Notion 3 trial, there were not much data. Most of the data were from registries. And then a couple of years ago, the activation trial was published, and it shows that for patients with severe aortic stenosis undergoing PCI as well, there was no overall benefit, but just an increasing risk of bleeding. However, this trial has some drawbacks. One is that it was stopped prematurely due to futility, so it was underpowered. And second is that this trial had a 1-year follow-up. So, and we know that PCI, the benefit comes on a longer term. So the short follow-up was also a drawback about this trial. And the third and also very important thing is that this trial included patients based on angiography of more than with a stenosis of more than 70%. And these patients, we know some of them will not have significant coronary artery disease when you assess them with physiology. So there are some important differences between the activation trial and the Notion 3 trial. According to the current guidelines, we should do PCI if there is a stenosis with a diameter of more than 70% in a major vessel. And this is based on no clinical evidence, so this is some kind of expert knowledge or consensus statement that comes up with this recommendation. So it's very vague recommendation. In this trial, in Notion 3, we included patients with severe aortic stenosis that was selected for TAVI. And then they needed to have a coronary artery disease, which was defined in this trial as either a very tight stenosis with a diameter of more than 90% or a positive FFR with a value below 0.80. There were some exclusion criteria. The two main exclusion criteria were left main stenosis and a recent acute coronary syndrome. Otherwise, from this, all patients could be randomized and put into the trial. We managed to include 455 patients fulfilling these inclusion and exclusion criteria. The main take-home message from Notion 3, there are several, but I think first of all, there was a reduction in the primary endpoint. There was a composite of all-cause mortality, myocardial infarction, or urgent revascularization at median follow-up of 2 years. This was mainly driven by a reduction in acute myocardial infarction, and the rate of this event was almost halved from 14% to 7% with PCI. In addition, there were reduction in urgent revascularization as well. So these are some of the main issues about the trial. Also, we found that performing PCI in these patients was safe, as there were very few complications. Of course, it needs to be interpreted in the light of the relative low syntax score of 9. On the drawback with PCI was we saw an increased risk of bleeding, but this was mainly minor bleeding, and this increased risk of bleeding is due to the more aggressive antiplatelet treatment for these patients, and this is stopped after 6 months. So there are some important issues that we will address in the future. And one is, of course, the long-term or the very long-term outcome for these patients. We'll follow all of the patients until 5 years. but we need to wait on for those results. Also, the use of FFR in these patients is still questionable, and in the trial we had a registry, and in this registry we followed the patient that had a negative FFR value. So we want to see whether it's safe to defer revascularizations in patients with a negative FFR value and severe aortic stenosis. And also there are some important subgroups that we want to look into, and that is of course the elderly patients, the young patients, also the patients that that has angina before TAVI, and also as we saw in our trial, there were interaction or almost interaction with diameter stenosis. And we want to look further into whether this benefit is affecting all endpoints. Or during the later years, there's been a tendency towards a more conservative approach for the coronary artery disease in these patients undergoing TAVI. And I think the notion 3, the results of this trial, will change that to a more aggressive approach. And based on these results, I think it's fair to say that PCI should be the standard of care for patients that have coronary artery disease and severe aortic stenosis. But the final decision should always be made on an individual assessment, taking into account the patient's risk of bleeding, comorbidity, the complexity of the coronary artery disease, etc.